Welcome to this explainer. Today, we are moving way beyond Psych 101 to explore the rigorous clinical foundations of psychotherapy. If you've ever wanted to map the intricate academic mechanics of the human mind and really understand exactly how clinicians diagnose and deconstruct psychiatric conditions, you are absolutely in the right place.
We've got a really packed syllabus today. We're going to navigate psychoanalytic models, mechanisms of ego defense, psychoanalysis techniques, behavioral conditioning, cognitive therapy, and finally, wrap up with systemic group family therapies. So, let's jump right in. All right, part one, we're starting with the heavy hitter, Freudian theories and the mind as conflict.
To really grasp Sigmund Freud's approach to unconscious conflict, we first have to look at his topographic model. Think of this as, well, a literal theoretical map of your cognitive architecture. Down at the absolute deepest level, that's the unconscious. This area operates on what we call primary process thinking, meaning it is entirely pleasure-seeking, completely devoid of logic, and you'll see it highly prominent in childhood or clinically in states of psychosis. Sitting right above that is the preconscious, which is basically a storage vault for easily accessible memories. And finally, the conscious mind. This utilizes secondary process thinking. You know, the logical, organized, mature processing we use to navigate our daily lives and actually delay gratification. Now, building directly on that map, we get Freud's structural model, which outlines the three interacting agents of the psyche. First up is the id. It's completely unconscious, present right from birth, and driven purely by instinctual sexual and aggressive urges. On the exact opposite pole, we have the superego, that's our moral conscience. It's driven by a strict internalization of cultural rules and is usually solidified by the time we're about 6 years old. And caught right in the crossfire, the ego. Developing after birth, the ego's exhausting, absolutely vital job is to mediate between the demanding id, the rigid superego, and external reality. And to survive this constant mediation, the ego relies on some highly specific tools.
Which brings us perfectly to part two, mechanisms of ego defense, where the mind unconsciously protects itself to relieve anxiety. When the ego needs to relieve severe anxiety, it deploys defense mechanisms to keep unresolved conflicts completely out of our conscious awareness. Now, it's vital to note academically that these are entirely normal and healthy when they're mature and used in moderation. Take altruism, for instance, benefiting others while simultaneously helping the self. Or humor, which lets us express unpleasant feelings without causing discomfort. Sublimation is actually a fascinating one. It channels socially objectionable impulses into totally acceptable actions, like, say, an aggressive impulse being safely channeled into competitive sports. And then there's suppression, which is the purposeful, conscious act of ignoring an unacceptable impulse or emotion just so you can navigate external reality. But things change quite a bit when we look at neurotic defenses. These are frequently observed clinically in patients with obsessive-compulsive and anxiety disorders. There's displacement, that's shifting emotions from an undesirable situation to a tolerable one, like yelling at your spouse just because you're actually angry at your boss. Rationalization uses explanations to justify behaviors. Intellectualization, this is a big one, avoiding raw negative feelings by hiding behind irrelevant academic details. We also see isolation of affect, reaction formation, which is doing the literal exact opposite of an unacceptable impulse, and repression, where a thought is unconsciously blocked from entering awareness entirely. Finally, we have immature defenses. These are heavily utilized by children, adolescents, or patients presenting with severe psychiatric conditions. Acting out is giving in to an inappropriate impulse just to avoid the anxiety of suppressing it. We also see regression to earlier developmental stages and projection of one's own objectionable thoughts onto others. Clinically, we really have to highlight splitting, labeling people as entirely all good or all bad. This is a classic hallmark of borderline personality disorder. We also see undoing, where a patient attempts to almost mathematically reverse a situation by adopting a new behavior. You see this prominently in OCD, like when someone repeatedly washes their hands to essentially undo a perceived harm. Moving on to part three, psychoanalysis techniques and application. Basically, how we bridge all this theory to actual clinical practice. So how do clinicians actually untangle these incredibly dense structural theories in a real session? Well, they use rigorous tools to bypass the ego's defenses. Take free association, asking the patient to speak whatever comes to mind without filtering, deliberately dragging those primary process thoughts from the unconscious right into the light. Crucially, they analyze transference. This happens when a patient unconsciously projects deeply rooted feelings regarding important figures in their life directly onto the therapist.
The rigorous interpretation of this transference is actually the core mechanism used to help the patient gain genuine insight. Of course, therapists must also constantly monitor countertransference, which is their own emotional projections back onto the patient.
But all of this raises a rather crucial clinical question that practitioners must objectively ask. Who actually qualifies for the demanding, intense, and frankly emotionally exhausting nature of traditional psychoanalysis? The clinical literature defines some pretty strict criteria here. The ideal patient is typically younger than 40, highly intelligent, non-psychotic, and holds a stable life situation, meaning they aren't mid-crisis like going through a severe divorce. But most restrictively, they need immense resources. I mean, traditional psychoanalysis mandates sessions 4 to 5 times weekly for 3 to 4 years. For patients who can't meet these extreme criteria, related modalities like brief dynamic psychotherapy constrain the process to a much more manageable 12 to 40 weekly sessions. All right, let's shift gears completely. Section 4, Behavioral Conditioning and Deconditioning. Here we look at the mind as a learner. Pioneered by B.F. Skinner, this paradigm completely shifts our academic lens. We literally abandon the search for unconscious conflict and view the mind purely as a learner, aiming to extinguish maladaptive behaviors. To do this, we really must meticulously contrast classical conditioning against operant conditioning. In classical conditioning, a neutral stimulus is paired to eventually evoke an involuntary conditioned response. Operant conditioning, however, dictates that behaviors are learned when followed by reinforcement. Positive reinforcement is giving a reward. Negative reinforcement, and this is a concept that is very often academically misunderstood, is encouraging a behavior by removing an aversive stimulus, like putting on a seatbelt to stop a car's warning time. That is distinctly different from punishment, which applies a negative consequence to explicitly stop a behavior. Because maladaptive behaviors are learned through conditioning, it naturally follows that they can be unlearned through precise deconditioning techniques. One highly effective method for phobias is systematic desensitization. The clinician steps the patient through a rigorous protocol, first establishing baseline relaxation techniques, then followed by meticulously controlled exposure to gradually increasing doses of the anxiety-provoking stimulus, all the way until complete neurological habituation is achieved. Now, a far more intense deconditioning alternative is flooding or implosion. In flooding, the patient directly confronts a real anxiety-provoking stimulus, whereas in implosion, the stimulus is vividly imagined. The clinical mechanism here relies on pure exhaustion. The patient is absolutely not allowed to withdraw from the stimulus until their physiological panic subsides entirely, and they finally find calm and control. It is intense, for sure. Let's move to Section 5, Cognitive Therapy and Distortions, Correcting Faulty Assumptions. Shifting our focus once again away from physical behaviors and directly toward the actual architecture of thought, Aaron Beck pioneered cognitive therapy. This approach meticulously targets what we call cognitive distortions. These are deeply ingrained faulty assumptions and automatic negative thoughts that actually drive psychiatric symptoms. The therapy systematically teaches the patient to identify these maladaptive frameworks and intellectually replace them with rational positive ones. Clinically, this is almost always combined with behavioral therapy, creating cognitive behavioral therapy, or CBT. You've probably heard of it. It's essentially the gold standard treatment for depression, anxiety, and OCD. And finally, Section 6, Systemic Group Family Therapies, Understanding the Mind in Context. Up until now, we've really only looked at the isolated mind, but systemic therapies analyze the mind as existing within and heavily influenced by a broader social context. Group therapy, which involves multiple patients with similar problems, offers some distinct clinical advantages over individual sessions. For one, it provides immediate, real-time peer feedback and support. But more importantly, it allows patients to gain profound clinical insight by directly observing complex interpersonal dynamics play out right in front of them. This makes it highly efficacious for treating things like substance use and personality disorders. When it comes to intimate relationships, therapists can select from highly specific, almost mathematically structured variations to address deep systemic breakdowns. These modalities range from conjoint therapy, which is seeing the couple together, to concurrent therapy, where they are seen separately by the exact same therapist. In highly complex situations, collaborative therapy assigns each person a completely separate therapist. And then there's four-way therapy, which involves the couple being seen together by two therapists simultaneously, dramatically altering the clinical dynamic. As we wrap up this explainer, we are left with a massive foundational question. When facing the profound, staggering complexity of psychiatric disorders, does the ultimate clinical answer lie in painstakingly resolving the invisible unconscious, rigorously rewiring the learned behavior, or completely restructuring the social system? Or perhaps true clinical mastery lies in knowing exactly when to utilize each. Thank you for joining me on this deep dive. Keep questioning, keep learning, and I'll catch you in the next explainer.